ميرسي دكتور وائل على المقدمة الجميلة دي. This is a great honor to present in this wonderful meeting. Continuing the pediatric cases, the last presentation about uveitic cataracts, now about the traumatic fibrotic anterior capsule with different approaches to attack. So fibrotic anterior capsule remains one of the most challenging situations in the pediatric anterior segment surgery due to poor visualization of the capsule edge, the high capsular elasticity in children, increased risk of radial tears, and difficulty in centering the capsular rhexis. And we are all thinking about the long-term outcomes for the children. Today I'm presenting two cases of traumatic pediatric patients with a fibrotic anterior capsule. So why does the fibrosis occur? Due to congenital cataracts, delayed presentation, persistent fetal vasculature, uveitic cataracts like the last presentation, and traumatic cataracts like this case. The pathology is the thickened capsule. Maybe there will be a fibrotic plaques. This is a metaplasia at the anterior capsule. Preoperative assessment can be a clue, like the UBM, and here we can see the plaque on the anterior capsule, under the anterior capsule. So this is the first case. You can see clearly that this is the white cataract with a fibrotic anterior capsule. I started with the cystotome doing the capsular rhexis. First, I was thinking that that was the capsule. Actually, it was not. It was a pseudo capsule, changing from the cystotome to the microrhexis. And again, I'm trying to do the capsular rhexis, and it was very difficult. So this was not the true capsule. I tried, but I'm afraid about the zonules. It's extremely fibrotic. I tried again with the cystotome, and again I cannot open the exactly the anterior capsule. And then I opened it with the MVR forceps. Different strategies. You can switch between different strategies, as Dr. Wael said in the first presentation. And then going with the cutter, doing with the IA, irrigation aspiration with the cutter, the vitrectomy, and then implantation of the lens. You can clearly see that the anterior capsule is extremely fibrotic. This is a hydrophobic single piece IL in the bag. Redialing it in the bag, and then bimanually you can do like fashioning. This is the micro scissor. It can be used inside the eye in the cataract surgeries along with the retinal surgeries. With the left hand, I'm right-handed. With the left hand, I was holding the microrhexis forceps, and with the right hand, the micro scissors doing fashioning. We're afraid of the capsular phimosis post-operatively, and this is a 15-year-old child, so I did not do posterior capsulotomy. You can do a YEG, and then continuing the case with the cutter, and then closing the case. The second case, you can clearly see that there is a corneal scar centrally. So that was an old presentation, delayed presentation of traumatic cataract. You can clearly see that there is a plaque or a plaque in the middle. The case of my dear colleague Hisham was above the capsule, but this is under the capsule. I was controlling with the cystotome, so I continued with the cystotome. Mostly the children anterior capsule is elastic, so we always use the micro rhexis. But at this case, I was controlling with the cystotome. So it's a surgical preference, surgeon preference, and then continuing. You must do the rhexis away from the plaque, because it will change your forces. And then I removed the plaque, going out of the eye as it is, and then continuing the cataract as usual. It's easy because it's irrigation aspiration. And at the end, I found a part of the anterior capsule. The fibrotic anterior capsule was not removed yet, so I tried with the cutter. I was afraid because I was not aiming to open the posterior capsule again. That was a 15-year-old boy. So I tried again with the bimanual technique, with the left hand the microrhexis forceps, and with the right hand the micro scissors, fashioning the anterior capsule, preventing the capsular phimosis, and then implanting uh, a hydrophobic. This is a 3-piece IL. I implanted it in the bag. So we can have this algorithm that in mild cases of fibrosis we can do the manual rhexis. The moderate cases we can be assisted with the micro scissors. If it's more dense, we can use the vitrector capsulotomy. If there is a severe plaque, we can use a combined approach, different approaches to attack this fibrotic capsule. So there's no a single technique that fits all patients. About the surgical pearls, that you have to use the cohesive OVD generously to stain the capsule because the visualization will be poor due to the white cataract. Doing the rhexis that's smaller than the optic. Remember that the anterior capsule in the pediatric population is elastic. Anticipate the posterior capsule management. We did not open the posterior capsule in both cases because more than 8 years. Having the scissors and the vitrector available in every case. About the pitfalls, please do not do excessive traction. Do not do tearing at the dense plaques away from the plaques, and use the tearing and not shearing technique. Please do not ignore the zonular weaknesses, and please do not keep the same strategy. Do not delay conversion between different strategies. So our major take-home messages that the fibrotic anterior capsule requires individualized management. Manual rhexis remains the gold standard when feasible. Scissors can be assisted in these different fibrotic anterior capsules. The vitrector capsulotomy in severe cases can be used, and you can switch between different techniques when one technique was failing. And remember that there's an important message that the challenge is not creating a capsulotomy, it's choosing the safest strategy for the capsule in front of you. And thank you so much.
ممكن كومنت بس دكتور وائل دكتور وائل
اتفضل.
استاذنك في كومنت صغير بس
اتفضل.
عندي كومنت صغير على الحالات اللي فيها ممبرين على انتيريور كبسول بالذات البوزيتيف فيتك زي دكتور هشام وزي بعض الحالات اللي عرضها نادر. في ساعات بيبقى الممبرين واخد معظم البيوبل فانا ما ببقاش شايف اللينس نفسها ما ببقاش شايفها في الاكزامينيشن فساعات يبقى الممبرين دوت ممكن يبقى بيلد بسهوله من الانتيريور كبسول ونكتشف ان اللينس نفسها كلير ما فيش سيجنيفيكانت كاترت فبس انا يعني بنصح في حالات زي كده ان احنا كيرفلي نشيل الممبرين اللي على الانتيريور كبسول بعدين نبص على اللينس لانها كلير احنا ممكن نسيبها يعني ممكن نكتفي بس بان احنا نشيل البليك ده.
Very nice presentation, Dr. Nader, very nice advice from Dr. Ayman. Definitely, the experience he has would add to the cases.